welcome everyone to the call. On this week's call, we have Shane Lawler from progolf-health.com and the Lawler, not the Lawler Clinic, but lawlerclinic.ie. So if you want to find out a little bit more about Shane, you can go there and find out a little bit about him. Just a quick background. I will let Shane introduce himself. I'm sure he could do a much better job than I can. But basically, Shane works with active release techniques, and he'll tell you a little bit more about those in a second. He's worked at the Titleist Performance Institute and with Gray Cook on functional movement screens. With regards to progolf-health.com, he works alongside world-leading professional golfers and athletes. So we are going to be talking about low back pain all the way through this conversation, and obviously you're going to be getting some sort of top quality information with regards to who Shane is working with currently and has worked with in the past. So you're in good hands. So hi Shane, how's things?
Hi Christopher, thanks for having me.
That's all right. So first of all, just to introduce yourself, really, just sort of who you are, what you do, how long you've been doing it, so on and so forth.
Did my undergraduate degree at the University of Glamorgan, which I now believe is the University of South Wales after joining Newport in the last year or so. So I have an undergraduate degree in chiropractic, and we were given obviously the strength of manipulation as a technique, and we were given some functional management and some soft tissue techniques and some rehab, but probably not enough that you're going to have to work with elite athletes or even the general public. So the way I look at any base degree is it's more or less like a driver's license.
Yeah.
So once I graduated, I started looking at what I hadn't strengths or weaknesses in and trying to fill those gaps. So I saw Stuart McGill quite quickly as soon as I graduated. I did dry needling. I did active release. And then when I started working with the golf company nearly 5 years ago, I started doing the Titleist Performance Institute courses, FMS courses. Started looking at more active care, because it's very easy for us manual therapists to be reliant on the passive care on the table, and not make the patient or client or athlete responsible on doing their homework or doing their bit to improve their health. Because effectively, when we see them in a clinic or see them in a sporting environment, we don't get to see them for that long.
Sure. So
over the last 7 years, I've more or less done as much as possible postgraduate, and even with traveling half the year, I still probably do 250, 300 hours of CPD. I've done DNS, I've done fascia manipulation this year. So trying to get the best bits and look at different schools of thought. So it doesn't matter if it's chiropractic or physiotherapy or osteopathy or sports massage or strength and conditioning. Everyone's got a part to play in back pain, and for me, nobody owns that domain.
Sure. Excellent. Yeah, I think that's a very important point to bring to back pain, because it is sort of multifaceted. We're going to talk about, I don't know, what you find as a sort of I don't want to say a major cause, but a contributing factor to low back pain. And it is, in my exploration of low back pain, it does bring in, like you said, strength and conditioning. You've got McGill, you've got Cook, you've got myofascial release. All these different subjects hold some nugget of information that is going to be useful alongside all the other nuggets of information that are useful. So that's always a good sort of mindset or philosophy to start from. So to start off with regards to back pain, in your experience with the different people that you've worked with, what have you found to be contributing or causing low back pain? Is it any one event? Is it a multiple of a sort of a multiplication of events? Is it an accumulation of incorrect movement? What have you sort of found to be the biggest contributing factor towards low back pain?
I think in general, looking at it and what I've studied, and as you said, I think exploration of patients is a really good thing, from trial and error and the mistakes they've made. And one of the most important things I learned was the case history.
Yeah.
Generally, if you ask the right questions of the patient, they'll tell you the factors that led to the injury or when it came on, or and a lot of the time it's cause unknown.
Yeah.
They haven't had a road traffic accident, they haven't had a fall, they don't have a repetitive job. But a lot of people are spending so much time sitting now, and that even goes for the elite athlete. So we spend quite a lot of time, for me, is trying to open them up. They open up their anterior chain and getting control through there that effectively the core goes to sleep.
Yeah.
Because it's so reliant on sitting down in a chair, and we don't get around and walk around. We're reliant on sitting down at a desk, sitting down at home on the sofa, sitting down in the office, sitting down in the car, sitting down on a plane. So over time, that's going to cause a lot of tightness, and I think it really dampens down our motor control.
Yeah. So with sorry, yes, carry on.
Yeah, no.
Okay. So with regards to the loss of movement, not only for the whole body because they're sitting stationary all day, but with regards to opening out the joints, what sort of effect on the core, and you've mentioned it sort of going to sleep, but what sort of effect is this stationary positioning or stationary position having on the lower back, and why is it maybe, if the problem's in the hips and the hips aren't moving, why is it manifesting itself in the lower part of the back?
Generally, if we look at, there's a lot of debate on which model is right, but if you look at some of Gray Cook's mobility stability patterns, or the effective, in my eyes, if something's not moving, then it's not going to complain.
Yeah.
Unless an arthritic or a labral issue becomes apparent. But generally, the lower back and the neck, for the instance, and the knee are the three major victims in the body.
Yeah.
They have to all those cogs in the body have to work somewhere, and the lower cervical neck and the lower part of the lumbar spine are the areas that are going to prime for overloading. And the fact that the hips don't move, whether it's external rotation or internal rotation, it'll vary from patient to patient, from athlete to athlete. The hips not being able to move, and yes, you're going to have tight hip flexors. I think they just become movement morons, so they just forget how to move.
Yeah. And
the fact of sitting down for long periods is never good on the intervertebral disc.
Sure.
Study after study show that the compressive load's sitting down, and if you're sitting down and twisting to any degree, or even repetitively under small motion, it's not going to be quite a nice experience for your lower back.
Cool, excellent. So if we've now sort of had a very brief look at maybe sort of how low back pain is manifesting itself. We've talked about the stationary position. We're maybe thinking about opening up hips and activating core and so on and so forth. If we've got now, we will move on with regards to the person that we're working with. So let's say we've just got a general, let's say, office worker. They, as we've talked about, they sit for long periods of time. If they were to come to you, what might be some of the very sort of first things that you would maybe get them doing or thinking about?
The first thing I'll do, always, irrespective of an 80-year-old grandmother or grandfather or a young athlete that might be 16 or 17, I'll always screen them.
Yeah.
Because you are effectively guessing. You'll know how they're moving, how they're getting out of the chair. You're already getting a picture in your head, but never assume that in one motion or one movement pattern that they won't move well in another.
Yeah.
And it does amaze me when you start studying. Like, I use the selective function movement screen, which is a lot more in depth than the function movement screen, and it always amazes me. What you're trying to find is that keystone of why they're not moving well as they should. Is it the foot up? Is it the T-spine down? Yeah. Maybe they have poor breathing pattern. Maybe they can't control the diaphragm and the pelvic floor in relation to the rest of the core. So I'll always screen them.
Yeah.
And I'll generally start them off nice and easy.
Yeah.
And a lot of floor-based exercise, whether it's DNS or McGill's Big 3, or hip mobility. But generally, I'll go after the hips. I'll generally go after the T-spine. I'll ensure that their breathing patterns are as best I can. So I often find now a lot of time I'm going into the diaphragm and doing trigger point work in there just to release a little bit and making sure that I'm using the breath through their whole cycle, because the amount of people that hold their breath during any exercise particularly if it's beyond their capability or their loading capacity, they will hold their breath and they will compensate. They'll either hold the breath or they'll bite down, or you'll see them gripping tight. So I always try and pick the right exercise for them if I can.
Sure.
But generally, I really like to get the hips moving and the T-spine.
Yeah.
And some dead bug exercises and glutes, and just try and reboot them in that way.
Yeah. I was going to kind of move gently towards that with this question. With regards to obviously screening someone and identifying problems, if you want to call them that, what have you maybe found to be like a general trend? Now, obviously, you can only really look at it on a case-by-case basis, but with regards to just as a general overview, what might be some of the general trends that you find? Is it majority towards the hips, the T-spine, the feet, the jaw, the neck? Where sort of do you find?
It seems to go across the board. I've very rarely not seen a lower back pain patient that had not had a mobility issue in their hips, whether it's external or internal rotation.
Right, okay.
That's generally always there.
Okay.
Generally.
Yeah.
For whatever reason. And then sometimes they'll have ankle dorsiflexion or ankle inversion, eversion, joint and mobility dysfunction.
Yeah.
It varies. It'll vary a little bit, and I never assume.
Yeah. Yeah. No.
What will be there, but generally the hips are always an issue.
Okay. Cool. That's
even if you look at the hypermobile patient, which is always a nightmare for us all, whether it's manual therapist or fitness professional, the fact that they have such huge range of motion, so gymnast, they still will have some mobility issues in an asymmetrical pattern.
Yeah.
So between left and right or right and left, that they will have some difference between. So try and balance them out.
Right. So it's sort of it's screening them, look at where the tight areas are in general, and then looking for any asymmetries from right to left, maybe front to back.
And some of the stuff I've been starting to use this year a little bit, we've always used manual muscle testing in our clinic and with the players on tour. And this year I was lucky enough to actually have time, so I went on neurokinetic therapy with David Weinstock in London. So hopefully I'll do the level 2 in Toronto. But he's also put some food for thought. There's a big issue in where you find a muscle that's inhibited or weak or whatever terminology you feel comfortable with using in your practice. But looking at compensation patterns, so it's always nice as well to take gravity out of play.
Yeah.
As important it is to load them through their feet and have them upright. Sometimes just bringing it right down to where they are, lying table and muscle testing to there, doing some of the DNS assessment, just seeing where they are without gravity in play. I think that's one of the nice things in the SFMA is the fact that it goes from the hardest task possible in those 7 tests and then breaks it down, taking gravity out of play.
So with regards to taking gravity out of play, is there sort of an anatomical or a physiological reason to do that, or is it very much just another form of testing just to get another, I guess, a second opinion on it? It's
twofold. One, it makes it you can really see their compensation patterns.
Yeah.
So it takes a lot of people find it hard enough to walk and to stand and to move around and jump and skip, and you might miss things, or they might be the ultimate compensator. They might be able to get around those things. Yeah. So sometimes you have to go at a microscopic level to look at a bigger level.
Yeah. Sure.
But what is very important, it's very easy to stay at that non-gravity, so you're floor based, but you still need to upright them.
Sure.
So some of the one of the things, like I'll start with some DNS, get some breathing patterns, start with some of McGill's exercises. But I in my head, if I can get them to hip hinge properly and deadlift and learn how to squat. I mean, one of the things that we're seeing a lot in Ireland, certainly with some of the Gaelic footballers, effectively, is a lot of them seem to have femoral acetabular impingement, which is obviously becoming a buzzword. It's a little bit easier to see now because imaging is a lot more readily available, and then with the advent of MR arthrograms where they can inject directly into the hip, it really helps clear for labral tears.
Right. So it's very
whether we're not the other issue might come to a head whether they do the research study. Sometimes these things, whether or not they become studied or not, is not a question for me because I'm I'm busy in practice trying to fix patients. But I think developmentally something's happening, and these young footballers and athletes are maybe not developing through their patterns. Maybe they're not spending enough time in physical activity, PE.
Yeah, sure. So it's very much using all these tests as a means of understanding their body. So using the static postures, i.e. being led down, to try and identify and take out, in a way, their kind of compensations and stability, to look at asymmetries. Cool.
Yeah.
So let's say we've met this client, we've assessed them. What might be some, I don't know, first ideas? I mean, are you going to be focusing on floor-based exercises? Are you going to be focusing on movement patterns? Are you going to be looking at squatting and deadlifting? What might be sort of the first place that you would take a client? Would you weight bear them? Would you actually get weights in their hand, or would it just be all body weight?
Generally, what I do if we're looking in the treatment setting, if I'm in clinic, I'll do the manual therapy that's required. So I'll do active release techniques, I'll do the needling, I'll do joint mobilization, manipulation, mobilization, fascial manipulation, everything that I have in the task, because depending on the patient, there will be techniques that suit them better.
Yeah.
So for instance, say if it's the right hip external rotation, so I'll do my best in that session to get as much mobility through there. So I will then bias it. I'll do some rolling patterns. I mean, it's probably one of the most underutilized exercises. It's very, very good. You can't cheat the system. It helps look at dysfunction, so you'll know what pattern, if it's flexion or extension, if it's the lower extremity or upper extremity. So I'll definitely lock it in with some rolling patterns, some bridges, some deadlift. Depends on where they're at. It depends. If they're not in pain, then I can do a little bit more, and slowly load them so that they're not in pain.
Yeah. With regards to the pain, what is the problem with them having pain whilst they are, quote, exercising? Is it inhibiting them? Is it just there as a mental gauge to stop exercise? What's the pain actually doing to the body?
Well, there's two ways looking, and I don't think anyone's got the full answer. I know Hodges has done some research that the motor control, their actual motor control, is affected around that area. So whether or not we should work the hip, or I've even seen some debate that whether you should actually exercise a client. So I can't work my lower extremity, I got back pain, I'm going to do the upper extremity.
Yeah, sure.
But pain will work globally. It's central. It's in the brain.
Yeah.
It could potentially affect the motor pattern through the whole pattern.
Sure. So
for me personally, I would rather the person out of pain. So maybe it depends on what stage. I happen to see a lot of chronic cases, so I can probably move them around a little bit, so they're not in that acute an issue.
Sure. So if people are experiencing pain, what is the advice? Is it to stop? Is it to change what you're doing? What might be something that they could do just in general? For back pain, is some people will do well with ice. Yeah. So 10-15 minutes, an ice pack. Generally, if you can get a good quality ice pack, peas or carrots will do the job, but a good quality ice pack, 15 minutes on, and then leave it an hour and a bit, and then put it on again. Yeah. But again, we've come recently, there's been a debate on whether ice works, but some patients get massive relief from it. So if they do, then I can't argue with that. Sure. I've certainly seen a better response to ice than heat. Right, okay, interesting, yeah. Interesting. Ice generally, in my experience, and I've happened to seen quite a lot of disc patients in 7 years, I don't know why, but I have, ice doesn't tend to help them very well. Right, okay. So sometimes I'll gauge it specifically on what they have. So if it's just a facet, let's say it's a facet sprain, they've irritated, it's a little bit, they get pain and extension, not too bad flexing forward, then ice will generally work quite well. Right, okay. I'm happy enough to work quite hard on their hip mobility, so figure 4 stretches, a frog groin stretch, anything that's going to be non-painful to their back, but still work on their key things that were highlighted on the SFMA. Sure. But if it's a disc patient,
I'm a big fan of some of the Mackenzie extension positions, but I always check them in the treatment session to see what they can tolerate. It's pretty good. It's from what I understand from what McGill said a couple of years ago. I'm not sure if that research was ever published. Was that the Mackenzie extension position had some centralizing effect on the disc material that was herniated or bulging.
Right. Okay.
They tend to do quite well in it.
Yeah. So far,
and keep them active, I guess. I mean, that's the most important thing. Bed rest is not going to help them at all. And always, the most important thing that I found as a manual therapist is always monitor their neurological findings. So always check straight leg raise. Always check their reflexes, muscle strength, sensation. Every session.
Yeah.
And I always have in the back of mind, this is a possibility that this back pain could be discal related, even if it's an annular tear without any bulging. I always keep it in my head. So I do nothing that's going to aggravate that, because sometimes it'll present as just a normal joint irritation and then it could turn into a disc. So I always keep that in mind. And what I always say even to our associates, you have to keep checking their neurology.
Yeah. So
and don't even if they don't have leg pain, I never assume that. I've had times where I've gone and checked, oh, actually that's a little bit numb, or that's a little bit increased sensation, or that those reflexes aren't matching.
Yeah, so that you're sort of moving now into, I guess, sort of a kinesiology type scenario. Would that be maybe fair to say?
Yeah, sometimes it's function over structure or structure over function, but you still have to check.
Yeah.
Check the neurological exam has to be done. That goes for if you're a medical professional that can't conduct a neurological examination, then it's always best to refer. For me, scope of practice is very important.
Yeah. So would that then imply that there is interference with the nerve, yet they aren't feeling any pain to sort of consciously be aware of it? Would that be?
Yeah. I've seen discal cases where they had actually the leg pain wasn't too bad.
Right. Okay. But the reflexes were gone.
Sometimes you won't get compression on the nerve root; it'll just be chemical irritation around that nerve root, so they mightn't have any symptoms at all.
Right, and
but
then
I'll always use McGill. One of the things I always kept since I met Stuart McGill and went to a seminar was I always try, and if it's a lower back patient, I'll always check their tolerance to compression, their tolerance to flexion and compression, because they'll generally tell you what they'll try and avoid.
Yeah.
Now there's nothing bad with flexion, but repetitive flexion and twisting is certainly not good for the disc. But you obviously have to load it a little bit. It's just that if you do it over repetitive area without the hip mobility, without the hip control, then it's always going to be a recipe for disaster.
Yes, that's probably one of the biggest things with regards to sort of McGill and Cook, because obviously McGill starts off quite static. Cook, in a way, kind of starts off trying to create mobility and things, but I sort of find trying to manage the static control and manage in a way the dynamic control. So just great,
side by side,
do it, but can you control it? Is I guess sort of the. I
mean, one of the interesting things, I think there's going to be a seminar in January with Stanford, McGill and Cook are both going to be there. But I know last year there was one with Pavel Kolash, who's the inventor or developer of DNS, and Stuart were in Stanford again, I think, and they assessed 3 patients.
Yeah.
I don't know if they had a back pain. I'm sure one had back pain. Despite this is the important thing that I've learned, despite their different assessments, I mean, we're all aware of what Stuart uses to assess, and we're all mostly aware of what Pavel would use.
Yeah.
But they came to the same conclusions.
Sure. Yeah. Different way of getting the same result in a way.
And all I would say is you have to pick a screen. You have to screen something. You have to use something, even if it's your own, and you repetitively do it, and you know it's reproducible.
Yeah. Sure.
And always keep going back to the screen as a mode to finding progress or regression or progression, or where that patient is with everything.
Cool. Excellent. Good information. I like it. So, we've looked at, I guess, sort of the general person. So we're looking at screening, and then we're looking at, in a way, sort of mobilizing as well, looking at hips and things like that. Now, when it comes to sort of gym enthusiasts or fitness enthusiasts, athletes, professional athletes, amateur athletes, so on and so forth, a lot of them are held in quite high regard with regards to, because they are athletes, and we obviously think, well, they must be in a good condition because they're athletes. Now, from your experience working with professional athletes, what have you found maybe within their body? Are they creating pain because they're not moving properly? Is it the repetitive action? What's sort of happening with athletes? Because it's just trying to get an idea of, don't always try and aspire to be like an athlete, because it's just maybe going to create just as many problems as you are sat behind a desk. Does that sort of make any sense?
No, it does. It does. Athletes are generally the biggest compensators in the world.
Right.
And they certainly don't like being put into they would deem baby-like positions, or asked to do rolling patterns to look at their core control or some of the DNS assessments or some of the SFMA. They generally don't like, but they're generally the best compensators. They can get around their physical limitations very, very well.
Right, okay.
And generally most of them won't get pain too often, really, because they have access to medical professionals and fitness professionals all the time. The problem when it comes to where general public starts to train like an athlete is that they mightn't have the base foundation.
Sure.
And they're certainly not going to be as good a compensator.
Sure.
So they will break down much quicker than a normal athlete.
And that's a very common pattern that
and what I find, even irrespective of the professional golfers that I work with, or professional athletes, or the Gaelic football players I work with, or the general public, they'll generally have the same starting point.
Right.
Because you'll have to regress them all the way back.
Yeah.
The good thing about working with athletes is their body perception is generally very, very good.
Sure.
So they can be progressed quicker.
Yeah.
And I'm always hard with the athletes. You have to start somewhere, and we need basic control of pushing, pulling, lunging, squatting, and they have to master those things.
Yeah.
And they always forget, because they'll always do it with their technical skills.
Sure.
They'll always practice. Like, take a golfer, right? Because I spend half my year working with them. They always put their work into the short game, their putting, their long game.
Yeah.
And they still have to do the physical work.
Sure.
Gym work. And sometimes they forget that doing those basics right is all they need to do.
Yeah.
In a sense.
So with regards to sort of maybe program design, you said we've got to regress them back. So in a way, they're all kind of starting from the same position, it could be.
Yeah.
So they're all starting with the very basic movements: rolling, squatting, deadlifting, possibly lunging as well, pushing, pulling, so on and so forth. With regards to maybe the general population and an athlete, how much time would you spend with a person in the general population working on general patterns? And maybe, because obviously an athlete has got specific movements that they need to do, how much time would you spend with an athlete working on those general patterns? Depends
where they are.
Right, okay.
Where it means that if they've come into me pain and I'm giving them a second opinion, they're going to start the same as the general public.
Yeah.
I've had times where I've had to say, okay, this person can't squat, they're not going to split squat, they've got groin issues or labral issues or lower back issues, so we'll keep it in the lower extremity. I try and individualize as much as I can.
Yeah.
And obviously there's buzzwords now, and sport specific, and as far as I know, and I'm pretty well read, there's not much to show that doing a sport specific exercise will translate directly into their sport.
Sure. Yeah, no, that makes perfect sense with regards to...
But what is important is that and there's also an important thing as well that sometimes isn't said. I know in my head when I work with my golfers, can I get them 100% symmetrical?
Yeah.
And it won't happen because they're playing a one-sided rotary sport.
Yeah.
So the repetitive rotation to the left of the right-handed golfer and the same the other way. So those things, there's an adaptive bias for them to have that dysfunction.
Sure.
And some players, depending on their proprioception, their body awareness, will benefit from having that.
As in having the asymmetry.
So what I do with the when I have the general public, I can probably do a little bit more with them because I know I won't mess them up. But if I have an elite athlete, I have to go less is more. So I'll only work on 2 areas because they'll be so adaptive to what I do that you could cause massive changes.
Sure.
So I'll pick 1 or 2 things that don't. I won't go after everything.
Yeah.
Because their feel, if we want to call it that, is a lot more aware.
Yeah.
And you can also progress them more, but they can be progressed quicker.
Yeah.
But I never underestimate that the ability that they need to be able to do the simple things well.
Sure. So with regards, if we take a golfer as an example, how is them being able to perform a squat or a deadlift, how is that going to, in a way, benefit their golf swing? Something sort of very basic to obviously do their job.
I think it goes back to them being basic movement patterns more than golf-specific patterns. But your ability to squat, push, pull, lunge in everyday life will translate into sport. And obviously squatting is really good, and deadlifting.
Yeah.
They're good posterior chain exercises, getting in the glutes and hamstrings and that whole chain. The fact that the golfer has to hit, well, say an average, if their average score a year was 72 shots on a round, so that's 72 rounds by 4 rounds. So it starts adding up quickly, and then the balls they've hit. So we want them to be able to tolerate those loads of swinging a golf club on a repetitive basis.
Right. So using bigger compound exercises are allowing their body to adapt to those tolerances, so they can go onto the fairways and hit those shots repeatedly, day after day after day.
Yeah.
Cool.
Yeah, because then effectively what you'll find with most golfers, if you MRI most of them, if you MRI them all, if we had access to PGA Tour and European to all of them, most of them will, in time, if not now, in the future, will have some degenerative change to the neck and lower back.
Right. Okay. So cervical and lumbar.
Yeah.
So with regards to the swing, because obviously we are sort of taught to the thoracic spine is where the movement occurs. Are they then getting movement from cervical and lumbar, and that's why the degeneration's there, or is it for another reason?
No, it's that part as well, because they have to rotate, and maybe they don't have the scapular stability or hip stability and mobility to control it. So something's got to take a brunt. But if you look at the body at impact, if you mimic it, put your arms stand upright, put your arms out, and mimic a golf swing and come at impact, there's going to be quite a lot of rotation at that impact position. So a lot of issues are going to be on that neck. Yeah.
So it's very
and everyone's different, because all the golfers are a little bit different. Some of them get a little bit more elbow issues, some get a little bit more neck, some get a little bit more lower back. But it all depends. It depends on their development, what sports they played as a kid, how much training they want to do.
Yeah, and I think that
a lot of golfers don't come into the sport because they want to be athletes. Sure. I think that's changing now, but a lot of them were gifted, and the most important thing about golf is getting that club face repeatedly to the same position on a repetitive basis.
Yeah, and I think that's a good point that you've just raised there with regards to the sports they did as a kid, because a lot of people, and this in a way kind of goes back to the general population as well, and they'll experience some degree of pain. Doesn't just have to be in the lower back, could be shoulder, could be knee, could be ankle, could be wherever. And they'll only look as far as what they did in maybe the last 6 months or to a year, and they won't necessarily take into account what they were doing 10, 15, 20 years ago. Yeah. And then that obviously then compounds and compounds and compounds, and then impacts them today, as it were. So I think that's another good sort of mindset to open people up, is to have that slightly longer term thinking okay, well, what was I doing? Because any good sort of consultational screen should really be taking that into account, because then at least it starts to build a picture of what that body's gone through in a lifetime, I guess.
Yeah, because generally you look at people's old war wounds, whether it's the general public or the athlete, you have to get a history. It doesn't matter if you're a fitness professional. The older the injury, you have to go after them.
Yeah.
And they generally won't have rehabbed that injury, so an ankle sprain or an ACL. I mean, sometimes the ACL rehab knee is much better than the non-rehab knee. Or
Sure.
so say they blew their left cruciate, and then they've rehabbed it, and they tend to forget about the right one.
The right knee that's been taking the brunt of the pressure over the time that they've been.
And their previous injury history has to be taken into consideration.
Yeah.
And when in doubt, get imaging. And most of us have private health insurance now. The UK, looking at the NHS, just pull yourself, get some imaging. Yeah. Don't X-ray for the sake of. You've got to have a reason if you want to rule out a discal issue. At the end of the day, if there's something, if I see somebody that comes into me in the general public or an athlete, and it's degrading every day, so their neurological symptoms are changing, or I've seen a change in their neurological examination, you have to refer out.
Yeah,
I've had a number of cases where, okay, this person's been to another health professional, and I've seen them a couple of times and said, okay, we haven't had any imaging, we've got some frank neurological findings, objective findings, not based on their subjective, but maybe they don't have a reflex or there's frank weakness of a muscle.
Yeah.
As much as we want to fix everyone, you've got to use the experts above your scope of practice as well. So from time to time, we have to send people out for surgery.
Yeah. So with regards to imaging, what sort of imaging would you ask them to go for? Are we talking MRIs? Are we talking X-rays? What sort of stuff would you get them to? Generally,
because MRIs are so readable now, and you can always, it rules out a lot, because you can still see facet or osteoarthritis, you can see a lot more structures. I'm happy enough to get an MRI.
Yeah.
Okay. There's no need for unnecessary radiation, but X-rays have their part as well, looking for fractures, and if you look at spondylolisthesis and anterior slippage of the lower vertebra, the lumbar spine, an oblique X-ray is probably one of the better things you can do, or a CT scan to see if there's a fracture of that part of the spine.
Cool. Yeah, excellent. I mean, it's taking, I don't know, I can only imagine it's just taking health and fitness just a little bit more seriously, because at the moment it's very much, it's just go in the gym, hit it hard, and...
Yeah, no plan.
Yeah.
No plan. And the problem for now, because we're in the midst of a recession, I know when I get there's miracle cures and somebody gets better in 1 or 2 treatments. Yeah. But if they've got a history, you've got to map it out them. You've got to give, like, I like to see them out of pain in 3-4 sessions.
Yeah.
But if I don't see an improvement, then I will get the imaging or some blood tests or whatever they need. But there needs to be a plan put in place.
Yeah.
And you've got to give them realistic goals, because they're going to have to do their homework. They're going to have to do their exercises. And as I see them moving better and I get their foundational movement patterns a lot better, then I always consult with strength and conditioning coaches that I trust. So I move that patient onto a strength and conditioning point of view.
Yeah.
And that strength and conditioning coach, if they see anything untoward or the patient gets a little bit of pain, then they're sent back into me again. But I try and make them as responsible for their well-being as possible. So they have to eat well, think well, move well, and move as much as possible. We're just spending so much time sitting down.
Yeah, absolutely.
Stress.
Yeah.
Smoking, drinking.
Yeah. With regards to their history, are you looking for patterns, or are you looking for any major incidents or accidents or injuries or whatever it may be? What sort of, causes a greater injury?
I never discount anything, because even the smallest little fall into the side, or definitely fractures of the big bones, so femurs and humerus and anything like that. For the female population, C-sections.
Okay, yeah.
Anyone with abdominal surgery.
Yeah.
One of the things I want to know where their scars are.
Sure. Yeah.
Because I've seen a lot of appendix scars, play around with some core stability.
Yeah.
C-sections. I think that's probably one of the reasons. If a woman doesn't have back pain up until giving birth and she has a C-section, she will be primed for back pain. I mean, you're cutting across all that abdominal fascia and core, and they need to know that they need to work much harder than they ever have to maintain that, and that scar needs to be worked with manual therapies.
Yeah, absolutely. And I think giving it that sort of approach in, as we've talked about, the history, looking at any patterns, any traumatic injuries, be it a surgery, be it a fall, be it an accident, or so on and so forth.
Yeah, and there'll always be a pattern. The most important thing, when you talk about the patterns there, and you asked me that question, you have to look at the patterns. Two things. Like, if I get somebody and they've been to 5 different people, I don't really mind what profession they've been to. I just need to know what's been done.
Yeah.
Have they screened you? Have they used some manipulation? Have they used needling? Did they give you homework?
Yeah.
Did they give you the wrong exercises?
Yeah.
That happens quite a lot.
Right. Yeah.
Like the full bringing knees to chest, and isn't it, people rolling around. It's like, it's not great on a flexion intolerant back. It's not going to like it very much.
Absolutely.
So sometimes even with the best of intentions and the knowledge of that medical profession, they're probably given the wrong exercises, and probably there's too much focus on the back.
Yes. Yes, I mean, it goes back to what you were saying earlier with regards
hips
to
and
seeing
T-spine, and I
hips.
mean, if I see somebody who can't load, say for instance, I start them and get the core working a little bit, because you want, we've seen a number of times, proximal stability before distal stability. But again, sometimes the foot's more important than the hip and core, so you chase after that. So you got to be able to encompass everything.
Yeah.
And sometimes people they don't ask the right questions of their clients. And the amount of times we all know, oh, actually, yeah, I did have surgery, or I did have this, and I do have reflux, or I have something that's wrong with me, and they forget to tell you.
Yeah.
And they also don't snoop enough into the patient's everyday life.
Yeah.
It could be the bed. It could be a change of car.
Yeah.
They could have been, they changed a gym. They changed an office chair.
Yeah.
The body's great at compensating over time, but I've had a lot of people, I changed my car, now I got some back pain. Or they, for instance, say, even one of our golfers, they change a little bit in their golf swing.
Yeah.
It's going to load their structures a little differently. And your body's used to a certain movement pattern, you start to load it differently.
Yeah.
And also it's important that they not be afraid to move.
Sure.
Because you have to load them.
Yeah.
Load them progressively and up to a stage where they're not in pain.
Yeah.
And make them not afraid to move.
Absolutely. And with regards to what you said just a second ago, with regards to sort of using questioning to be able to get the right information from them, if, for instance, and I guess this is maybe an answer that trainers might be a little bit more interested in, if you did have a client that you were working with and you sat down, you did a consultation, you've done your assessment, and then 3 weeks in, it just comes to them for whatever reason. Maybe you asked them questions during the previous sessions, but it comes to them, oh yeah, and this happened. How would you manage that? Would it just be cut back on what you were doing? Would it be obviously depending on what the change is and what the answer is, but how would you manage sort of information that comes in after the date that you've, in a way, sort of planned the session?
I think you'd know. I think you'd know as a trainer that maybe it wasn't going the way it should be.
Yeah.
And if they're not getting, well, 2 things will happen with anything, with any input we put into the system as a manual therapist or a fitness professional. They're either going to stay the same, they're going to get worse, or they're going to get better.
Yeah. Cool.
And yes, they may forget to tell you stuff, but you just keep it into the pattern. But it might be an important clue of where they're saying, okay, I have to sit down. I used to do lab work, and I used to stand for 8 hours. I was fine, but now I'm doing a little bit, correcting more examinations from students, and I have to sit for 8 hours. Or you have a student that, I've come up to exams, and I think sometimes people get a little bit mad at themselves. Their patient isn't getting better, their client isn't getting better, but don't forget what they're doing at home.
Yeah.
They might have say, okay, you started training them in August or September, and they're doing really well, and then it comes to October and they have some exams and they've been sitting down more for 3 months, or for say 2 or 3 weeks studying more. Yeah.
And I think it's very much, when I spoke to Gray Cook, he was saying similar things, but in a different way. In that, you've got to be able to use, obviously, your intuition. You're going to learn about that person over time. You may not get all the information in that first session, but obviously, being intuitive, like you've just said, is this person getting closer to what I was expecting them to? Are they getting further away? Are they changing? Are they moving in the direction at least? And again, it's being able to use that intuitive trial and error experience to maneuver them in the right way, using exercises, using evaluation, using various different forms of assessment to be able to do that, I guess. I mean, is that a sort of a fair assumption?
No, it's very fair, and I think we all have the one thing those. It depends where you are in your stage career. Look, I'm lucky enough to have 7 years experience. I've met some of the best manual therapists and strength and conditioning people in the world, and I can call them or ask them questions. But the one thing we shouldn't be afraid to make mistakes.
Yeah.
And the one thing that I've most learned for whatever you do, whatever input you put, less is more.
Mm-hmm. Pick
1 or 2, 3, 4 things to do and get the patient to do them well, and the client to do them well.
Yeah.
Because you'll get better gains.
Yeah.
I've had a lot of times where a patient's been in from a fitness professional or a medical professional, and they show you the program,
mm-hmm.
and they have 15 or 16 exercises. It takes me an hour and a half to do.
Yeah.
If you can get somebody to exercise for 20, 30 minutes to do some mobility and stability work, and they're progressing through what your planned
mm-hmm.
program, then it's absolutely perfect.
Yeah.
They buy in, because there's no point, an hour and a half, this is going to take me so long. They won't buy in.
Yeah, sure. And on a personal level, because this is something that I keep telling the students that I work with. When I'm stood up and teaching, I might get someone, put them through sort of a full squat pattern, and I'll pick up, ankles, hips, knees, shoulders, neck, I'll pick up on all these bits, and then in their heads, because they're sat there going, oh my God, this is a lot of information, it's then, as you've just said, it's breaking that down and thinking, right, okay, for this week, or for this exercise or set, I'm just going to look at the ankles. I'm just going to see what's happening with the ankles. And then I might explore just up in the hip and have a look up there and see how that affects the ankles.
Yeah.
So you're not trying to look at the whole thing all the time. It's
you're chasing a rabbit.
Yeah.
You're chasing a rabbit if you go after everything.
Yeah.
It has to be a little bit imperfect. It can't be perfect.
Yes.
We don't have the time. They don't have the time.
Yeah.
And you've got to hedge your bets. As you get more and more experience, you'll know where to go.
Yeah.
So it might be a foot-driven problem. It might be the hip is driving all the back pain. It might be that they have poor breathing patterns, that they smoke. That might be the major issue.
Yeah.
Don't discount what bad nutrition can do. They might be pro-inflammatory. They could be diabetic.
Yeah.
And you're right, just distill it down to 1 or 2 things.
Yeah.
Because if you try and treat everything, then you won't know what's caused the problem.
Mm.
You won't know what's successful.
Yeah.
And the worst case scenario, you can play around with that in the treatment room and in the fitness area. Just do 1 or 2 things.
Yeah.
And again, it'll come to 3 things. No change.
Yeah.
It'll be worse.
Yeah.
Or it'll be better.
Yeah. And I think having that is so refreshing, because there's so many trainers, therapists, I speak to a lot of people, and that's one thing that they stress about. But it's look at it over time. Give yourself and them the chance of look at it, let them go away, come back next week, we'll talk about it, we'll try something, and we'll move on a sort of a week by week basis, but following that general trend in the direction that we want to go in, if that sort of makes sense.
And I think sometimes there's a lot of debate in manual therapy whether you treat the patient on the first session. Mm-hmm. So I bring somebody in for a consultation, say I bring you in as a patient, you got lower back pain, I screen you.
Yeah.
If they're in a lot of pain, then I'll generally do some pain relief for whatever needs to be done.
Yeah.
But generally, if somebody's got a chronic problem and they've seen a lot of people,
mm-hmm.
it's of no benefit for you to start the treatment in that session.
Yeah.
So I say I'll go away with all the screens that I do,
mm-hmm.
SFMA, FMS, the DNS ones, some of the other things that I've learned from other people like Craig Liebenson, and I may see what Gray Cook does, and I see what with Stuart McGill does, and use all those bits and bobs and try and put a picture of this patient into and sometimes you just have to step away and then put a plan in place. And if you say this is what needs to happen, they'll respect you a lot more. Because there's no quick fix in life.
That's right.
And no matter how healthy we think we are, we always have to put in a little bit more effort. Even ourselves, we have to do a little bit more mobility work. We have to do a little bit of control.
Yes.
We have to eat a little bit better.
Yes. Oh, absolutely. I've literally just come from having a full body massage, and she's telling me how stiff various joints are and things like that, and I'm thinking, oh Christ, I'm supposed to be the expert in all this, and it's just one of those things that go off in your head.
And one of the important things as well, if the patient and client's making progress, and they've done it over long periods, and say it's a long-staying patient, one of the things that we've also got to regard people getting cloud, just they see all this stuff wrong with their client.
Yeah.
No client will ever have a perfect screen.
Yeah.
Because they're doing things every day that's erasing that progress. As much as you're taking steps forward, you're going to take 1 or 2 steps back, and that's what you're fighting.
Yeah.
And sometimes patients should respond in 6 or 7 treatments, but maybe they've got a lot of stress at home.
Yeah.
They're not eating well. They're not sleeping well. That's going to affect the recovery. Then you've got to say, okay, it's going to take a little bit longer.
Yeah, sure. So it's very much in a way it's sort of a management, but trying to get the most out of them in that management of doing it, I guess.
Don't expect to be perfect.
Yeah, big time.
That'll be boring. If all patients were supposed to follow everything that we'd
have nothing to do.
No.
Nothing to say.
At the end of the day, back pain is here. It's going to stay here. It's probably going to get worse.
Yeah, sure.
I mean, I've seen quite a lot of Gaelic players in Ireland. Certainly, it's one of the population I see a lot of. There's a lot more labral tears. Whether we're finding more and they're not symptomatic, it just means bad hip health.
Yeah.
Whether they have the FAI or they don't. Like if they've got bad labral tears and they have FAI, I can't load them into a full squat. So I've got to walk around and maybe they do some single leg deadlift or a little bit of a split squat, but try and keep them out of that past 90 degrees.
Sure.
I mean, there's other sports. Ice hockey is another sport that sees a lot of groin issues.
Cool. Brilliant. Well, we've had a good conversation. We've asked a lot of questions, answered a lot of questions. So I think we've got plenty of information to digest. Maybe some point in the future we'll be able to connect again and discuss a little bit further, but I don't really want to take up any more time. I am sort of conscious that we're coming towards that 60-minute mark, so I guess we'll finish there, and if at some point in the future we get to contact each other again, we'll be able to maybe discuss it a little bit further and maybe take some of our
maybe a little bit more clinical scenarios and things. Yeah,
absolutely.
I'm happy to do that. Yeah.
Cool. Well, thanks a lot for coming along. Hopefully the listeners at home have had some good information that they'll be able to sort of take away with them, albeit general public or trainers, therapists, whoever. That would be great. So, I guess it just leaves me to say thanks a lot for coming on, Shane, and hopefully we'll speak again at some point in the future.
Thank you, Christopher.